Coming Together for Sexual Health engages you in shameless conversations about sex-positive, identity-affirming sexual health care. We keep our attention on those most impacted by STIs, HIV, and structural barriers. We're powered by nationally recognized experts in sexual health at the University of California, San Francisco, and the California Prevention Training Center. All views expressed are those of the person speaking and not of the CAPTC or their employer. My name is Tammy Kremer. Let's come together for sexual health. Welcome to the second episode of the three-part Family Planning and Reproductive Justice series here on Coming Together for Sexual Health. Today, we're joined by Mariana Horne and Dr. Jen Karlin, and we're going to be talking about the edges of conversations we have about contraception. Things that don't often get talked about, types of birth control options, and side effects. So I'm going to start by introducing Mariana Horne. She's a health educator and outreach lead at UCSF New Generation Health Clinic. She has a strong commitment to addressing racial inequities and disparities in reproductive health care and has been a prominent advocate and educator for anyone in need of reproductive care, particularly monolingual Spanish-speaking communities. So welcome, Mariana.
Thank you so much.
And we also have Dr. Jennifer Karlin, MD, PhD. And Jen is a board-certified family physician and family planning specialist whose primary care practice is anchored in caring for patients in a way that encourages their empowerment and autonomy. She's trained as an anthropologist and historian of medicine, and her research aims to understand how social, political, and institutional structures affect people's experiences with diagnosis, treatment, and healthcare. Dr. Karlin is also committed to medical and resident education that aims to encourage physicians in training to approach their practices from an historical, trauma-informed, and self-reflexive perspective. Welcome, Jen.
Thanks so much. I'm so happy to be here.
I'm so glad to have both of you today, and especially to have the two of you in conversation. And I want to start us off by talking about what experiences you bring when it comes to supporting people in choosing and getting on birth control. Mariana, if you want to start.
I'm a health educator and the first point of contact with patients. I'm a certified family planning counselor and also I'm a data reporter. So I educate people about the birth control methods that are available for them, and I share the information for them to make an informed decision.
Great, thanks. How about you, Jen?
Yeah, so I am a family doctor, which means that I take care of people from birth until death. And I have focused fellowship training in family planning. I really focus on sexual and reproductive health for my patients. And my background is in anthropology and history of medicine, and really thinking about how can the healthcare system meet people's needs in ways that are more empowering for them. And that has meant different things in different places across the world and throughout time. I really came from this from an experience earlier on in my life where my mom was pretty sick when I was young, mainly through high school. She had lupus and was constantly seeing doctors and was misdiagnosed for years and had physicians saying all sorts of different things to her, like, you know, you're probably just too stressed, and that's the reason why you're feeling this way, or it's because your daughter is going to college, or it's because you're a business owner. And we used to sit at home thinking, why are people saying these things to you? And I got really curious about the ways in which we think about patients and people were constructed. And later on, actually, my mom ended up passing away from inflammatory breast cancer. And she had missed her mammogram by about 6 months. And a doctor literally said to her, well, you missed your mammogram. Now we can't fit you in. She used to tell me that every time she would see him in the hallway of the hospital afterwards, she would want to turn around and run away. It was a really eye-opening experience as a young kid. And so that's sort of the reason why I wanted to go get background training in anthropology and history of medicine, but also wanted to be able to be a practitioner to see if we could take those lessons and actually put them into action in the clinic setting.
Thank you for sharing that. I can understand how growing up and seeing that must be so confusing to have that contrast and negotiate that.
I want to say that, Jen, thank you so much for sharing your story. It's very inspiring.
My story is a little bit different. I come from a very Catholic family where none of the information was available to us, only what we learned at school and little that we learned from our parents, which was if you kiss somebody, you can get pregnant. I remember some of my friends went to their first OB appointment. And I was just very curious because it was not until like late in my late teens that I decided I don't care if my parents know that I went to an OB because I'm using their insurance, but I need to go just to ask questions. I had a professor that she was just talking to us about reproductive health, and she was an OB, and I just went to have an appointment with her. And I was just like, I just don't know anything. And she was like, you know what? Thank you for coming. So I remember that first appointment was kind of like 2 hours, just like talking. She was one of the first persons that said, is your body is your choice. And I'm like, oh, wow, I have a say in what happens with my body. That resonated with me so much. And she was like, there is a career like reproductive health and public health. And I'm from Mexico, so it was a long track to get here. And here I am advocating for reproductive justice, advocating for people that are monolingual Spanish speaking and they feel that they don't have a choice or a say in what happens with their bodies. They're surprised to hear that they can choose. And I just love being a health educator.
That's really powerful to move from the place of your own experience of not having access to information. And I want to ask both of you, what are your priorities and values when you're working with clients who are interested in getting on birth control? And can you share an example of a way that a conversation might play out about that?
First of all, I also wanted to mention that I was partly trained at New Generation. In most of healthcare, you have to go to the doctor between 8:30 and 5, and that's usually the time that lots of people are working or in school. And what is so empowering about the model of care at New Gen is that people can drop in later in the day and on weekends. The kind of space that creates when you allow people to have a conversation that is maybe intimate for them. For some people, talking about contraception is not intimate at all, right? Just allowing them to choose the time and place to do it sort of talks a little bit about my values. I try to be as open ended as possible and learn what is someone looking for from the conversation. It might not be that someone is looking to start contraception right then, but they're looking to learn more about themselves and more about their body and the environment. And so offer additional options that people may not know about, but offer them in ways that doesn't feel coercive at all. So saying, would you like to hear more about this? So, for example, I have a patient that came to me. She was an older Latina woman in her 40s and was having a lot of heavy bleeding from fibroids. And she had had a lot of sexual trauma, also pregnancy loss. And a provider had told her previously that a way to deal with her heavy bleeding would be by putting in a progestin IUD. So putting in a Mirena. So she had come to me to place that Mirena because the provider who had told her that felt uncomfortable placing it with the fibroids that were in her uterus. And I could just tell that she was so scared of doing this, but felt that she had to because she felt like if she didn't place the IUD, she would continue to have heavy bleeding and suffering. This was really the only option that she had been offered. And so, at some point I said, you look scared. Can you tell me a little bit about that? And she started telling me about the pregnancy losses she had had and how she actually had had an IUD before and then had a miscarriage and was scared that that was what had caused the miscarriage and held all this guilt. And it was complicated with some sexual trauma she had had previously. And so I said, you do not need to do this. We can find another way to manage your heavy bleeding. And just the fact of being told, like, you don't have to do this right now, gave her the space to, like, actually think about other options. So then she left and came back, and we used an injectable contraception, Depo Provera, to help manage her heavy bleeding. even though I want to have conversations that feel comfortable with people, I'm a white provider. I am in my mid 40s. I am highly educated. So there's a lot of power dynamics that go into the conversations that I have. And I think it's really important to pick up cues and be slow and not just try to, okay, this person is scheduled for an IUD. We're going to place the IUD, like even if they look a little scared, and not actually open up that conversation because that conversation took 45 minutes in a 15-minute slot. But those are the conversations that are just so important to help people feel in control of their bodies, both within the clinical space and then when they go outside the clinical space, which is actually what's even more important to me because that's where they're spending most of their time. So I want them to take that feeling of autonomy, of like, oh, this is my body. I get to make choices about it. I want everybody to walk around the world knowing that and feeling that and acting that when they're not in the clinical space.
I'm so happy to be in a space talking with somebody that shares the same values and the same priorities. The beauty of NewGen is, although there's like 20-minute slots for the patients, we just don't stop right there. Like if somebody needs to talk over and over again, we just stay there and talk with them. And I feel like a lot of people have this sense of, if I go to the clinic, I'm committing to something, and just telling them, you don't have to. They say, oh, thank you. I didn't know that that was an option. I'm like, that's always an option. We see all ages. When we see young people, how comfortable are you choosing this birth control method? Or is someone forcing you to get on this birth control method? Check for their safety too. How many sexual partners have you had in the last month? And I have different options here, like testings too. If you need some testing, we can also do that if the sex is consensual at all times. And when we tell to people, you can say no at any point, even if you started by saying yes and in the middle you decide that it's a no, it's your right. Especially youth, they don't know that this is a choice. And when you tell them, they're like, oh, I feel empowered if I don't want to have sex. Or if I want somebody to put on a condom and they didn't, like I have people that can help me out. I talk to people about their rights, especially in California. If you're in school, you have a right to get out of school at any time. You just have to talk with a nurse and they have to let you come to the clinic for your reproductive care. We also go into what are the stigmas or beliefs around birth control and how we can have a healthy conversation about it. As somebody that came from a very Catholic family, we were told if you don't bleed, you're accumulating all the blood inside of you. And I'm like, oh, let's talk about that because that's not what's happening. And I bring props and everything. And I'm like, this is what happens in your body. And this is how the hormones work. And when they see how the hormones work, they're like, oh, I didn't know. If I could skip my period every other month, I would do it. We do see a lot of monolingual Spanish speakers. And this is a story that breaks my heart, but I feel I have to share it. One of the patients came to the clinic. She gave birth on the border. She said, they just handed me paperwork in English. I don't understand English, but I had to sign it because they were forcing me to sign something. And before she saw the baby, they just placed an Exponon under her arm. And then 5 minutes later, they brought her baby. And she was like, I don't know what is this that they put under my arm, but it hurts and I'm feeling very uncomfortable. She was sharing all the side effects of the birth control. She was just like, they told me that I can't take it off in 3 years. And I'm like, no. How long have you had it? And she was like, 2 months. So I was, we can definitely take it off. You don't have to wait 3 years. And if you decide that you don't want to get on birth control, you don't have to. Historically, Black and brown women have been coerced or forced to use birth control to stop procreating. And my inside was boiling. Just why nobody talked to you about this? They made you feel that you don't have a say. Just because you're new to the country doesn't mean that you don't have a right on what happens to your body. And she was like, can we talk about other birth control methods? And I'm like, totally. After talking to her for like 45 minutes, she was like, I don't want it. And right now I'm scared to use another birth control method. And I was like, okay, you don't have to get on birth control. We also have resources of assistance. You need housing, you need food, you need shelter. What can I give you so you can go home with a lot of tools for you to feel that you got something out of us and that you feel safe and you feel comfortable coming back or calling us if you need help with whatever it is.
Mariana, that story brings up so many important points, I think, that I come across too. One, this misconception that if a contraceptive is placed, especially a long acting reversible contraceptive, that it can't be taken out. And I think it is so important. It is one of the first things I say when I place an Explanon, for example, is this is going to go in really easily, but it's much harder to take out. So I just want you to know that if you get this placed, we can take it out tomorrow. We could take it out in a week. We could take it out in a month. We could take it out in 5 years when the progestin is running out. And then it's the opposite with an IUD, right? Like it's just going to take a little while to put in, but taking it out is super easy. And in fact, you could do it yourself. I can leave the strings really long and we can talk about you being able to remove it whenever. And I think that's really important because when lots of providers share information about birth control methods, they'll say that can be in for this many years and this can be in for this many years. And people interpret that as I'm supposed to keep it in that long. And then also what it must feel like to have something in your body that you don't know what it's doing and how uncomfortable that must be, like that would make me scared of putting anything else in my body, right? And so I think as a provider, another one of my values when I'm talking about contraceptive options is talking about the side effects and the effects that the hormones have from the get-go. Because if you minimize them or hide them and they happen to somebody, then somebody's sitting there being like, wait, I got this thing. I totally trusted the person who put it in. And now I'm having this experience of my body that I never even heard about. I just like to tell people, that this isn't the majority of the people, but some people experience this.
Yeah, I'm a huge advocate for sharing the information about even how uncomfortable is a procedure is going to be. Let's talk about how we're going to manage the pain. We show them the tools that we're going to use, what's going to happen throughout the whole procedure. And at the end, we ask them, like, sometimes they're like, I'm in a lot of pain. And sometimes, oh, actually, it was not that bad. Following up with the patient a few days or a few weeks later, we've even had patients that have come that have private insurance and they put an Explanon on an IUD, and private insurance are, no, you have to wait until 3 years, 5 years, 7 years. We just sometimes see the cost of the service and we're like, okay, they told you that they can't remove it. We will do it because we believe in you have a say in what happens with your body.
Mariana, that's interesting because that brought up to me the varied experiences that I have seen of people responding to different procedures. So some people have an incredible amount of pain from a IUD placement, and some people experience that as sharp pain. Some people experience it as cramping. Some people experience it as a tinge or bloating, right? People describe it and experience it differently. And then some people don't even feel it at all. And it's always amazing to me. I never know who is going to have a different experience. And so I try a lot not to name the experience that someone is going to have. So I try not to say you are going to feel pain. I try to just describe, especially while I'm doing the procedure myself, I am now touching your leg, not you're going to feel my hand on their leg. Because what if somebody was numb there and didn't actually feel my hand? I don't know what they're going to feel or experience. And so I try to just name what it is I'm doing, because sometimes I wonder if that takes out a little bit of the judgment or the idea of like, oh, I should be feeling this way. And that certainly has been my experience. When someone else is describing to me personally what I should be feeling, I start having these thoughts in my head of why am I not feeling that, or should I be feeling that? So because that's my experience as a patient, I try not to do that as a provider.
Yeah, and I'll say, like, when I had my IUD placed, I was surprised by how little pain there was, and also, once I had it done, I looked back and I wondered what had scared me so much about getting some kind of long-term birth control method. And I think the conversations that you're describing of really sitting down with folks and going through the different options may have changed my outcome, where I did end up having an abortion despite using a barrier and despite taking emergency contraception within like 6 hours. And I don't think I knew at that time that getting a copper IUD placed within 5 days could have prevented a pregnancy. And I don't think I knew at that time that the weight cutoff for emergency contraception, the form that I took at least, was like 150 pounds, which was incredibly shocking for me to discover. To me, that feels very low. And I think there was this kind of like double edgedness about like, it's so great that emergency contraceptive pills, at least at that time, were very easily available for me. But yet the flip side was I just kind of had in mind, oh, this is what I'm supposed to take in this situation. I actually did have more than one choice. I didn't know that.
Tammy, thanks for sharing your story with us. I'm sorry that was your experience. And I think it is an experience that a lot of people have, even being in the field. Like, there's new methods all the time and there's nuances to them, right? And so we're all constantly learning about them. What feels sad to me about your story is if someone just took a second to say to you, hey, there's this other option, and what do you think about this? Maybe you would have explored, oh, I am scared of getting an IUD placed because I have this idea that it's going to be really, really painful. And somebody could have said, yes, some people experience it really painfully, and some people don't have that experience. And you could have also, troubleshot. I mean, there's a lot of times when I'm placing an IUD where I say, listen, you're totally in control. If there's any point where you want to stop placing this at any moment after I place the speculum, I mean, it's just not a dangerous procedure. So you can stop at any time, right? If it gets to be too much, just let me know. You have options for anesthetic blocks. So numbing the cervical nerves so that people have less sensation during the procedure. And I think what's tricky about all of this is saying, there are all these like different sort of options. And sometimes those conversations take a while because they're not black and white. Even if we give an anesthetic, some people still have sensation with the anesthetic. But you're never going to know unless you ask.
I think there was also, for me, a profound strangeness about the idea of having something that stays in my body. And I think particularly as a younger person, at least in my situation, there's maybe been less interaction with the medical system and maybe less need for trying different types of procedures and medications. So there's a bit more of that kind of strangeness of it all. In each of the 3 episodes on family planning and reproductive justice, we're showcasing relevant projects by our colleagues at the UCSF Bixby Center for Global Reproductive Health. The Bixby Center focuses on advancing reproductive and sexual health worldwide. Here's Bixby Center Director, Dr. Jody Steinauer.
As a contraceptive care provider myself, I have learned firsthand the importance of trusting people to know what's best for their bodies and their lives. There are 2 programs that I want to mention, especially for people who provide contraceptive care, that will help us improve the care we provide. The first program is called the Person-Centered Reproductive Health Program, PCRHP, in the Department of Family and Community Medicine at UCSF. PCRHP, under the direction of Dr. Christine Dellendorf, has developed a set of amazing resources to make contraceptive counseling more responsive to people's needs and values. My favorite tool that they have developed is called My Birth Control. And this is an interactive online tool that helps patients identify what is important to them in terms of their chosen contraceptive method, and then can be used by clinicians when they interact with the patient to facilitate really high quality shared decision making. You can find this resource on clinic.mybirthcontrol.org. I want to also recommend the site called Innovating Education in Reproductive Health, which is a hub based at Bixby Center that has many, many free online courses available to anyone. These include courses on abortion and many on contraception, including contraceptive counseling and methods of contraception. It can be found at innovatingeducation.org. And I want to close by just thanking you all for taking the time to learn about this. to improve the contraceptive care you provide.
I'm kind of curious to get into some of the specific birth control options that you might discuss with patients, and in particular, ones that maybe we don't hear about very often, and some benefits, drawbacks of these different methods. And if we can start with Nexplanon, because I know we've been mentioning it, but we haven't explained what it is.
Yeah, Nexplanon is a device that is a size of a matchstick and it goes under your arm. It's placed at a clinic and it has only one hormone, which is progestin only. Recent studies have shown that it's good for up to 5 years. Initially, it was only for 3 years. Some of the side effects are irregular bleeding or spotting. So we do share that information with people. The lining of the uterus is just creating like very thin. So the little that it creates, the little that it's going to start shedding. So that's why you have irregular bleeding or irregular spotting. Some people have mentioned they stop bleeding, and some other, even though it's a regular cycle, they kind of know their body or start to understand their body to know, oh, I'm going to start spotting here and there in the next couple of days. We also share, some breast tenderness here and there or some headaches. Some people have mentioned some weight gain, some weight loss, and mood changes.
That's a great example in terms of the kind of information that you might share. And if we can talk about IUDs and what are some symptoms people might have or some side effects, in particular, those that folks might not be expecting. And Jen, do you want to take this one?
Oh, sure. I loved your matchstick, like the size of a matchstick. I was like, I'm going to use that. So IUDs, similar to what Mariana said in terms of size, it's like if you could imagine two matchsticks placed together perpendicularly into a T. It could either contain a hormone or not and just be made out of copper. It's placed through the vagina, through the cervix, into the top of the uterus. The copper IUD does not have any hormones in it. So there are less systemic effects, but it has been known to create heavier periods. So people who generally have more painful and heavy bleeding might have heavier bleeding and more painful bleeding. The irony of this is that when I actually got an IUD placed, a copper IUD, when I was in medical school, I actually had less bleeding, and that was kind of amazing. But I had the worst experience of placement. Like, it was so painful. They had to try 3 times. They eventually used an ultrasound. So I definitely am one of those people that are like, it can be like terrible to place it. But honestly, my bleeding just like decreased. So sometimes, you just never know what someone's experience is going to be. For the progestin containing IUDs, those, again, similar to the Nexplanon, can cause irregular bleeding. They have a little bit less of those sort of systemic side effects that people experience with either progestin injectables or pills or the Nexplanon, because it's more of a local progestin effect. But you could still have some of those experiences. But mainly it's the irregular bleeding or not having any bleeding at all. And Mariana kind of talked about this before, but there are a lot of people who are uncomfortable with not having any bleeding. And it's not just because they've been told that you need to bleed every month, but a lot of people will tell me, I just like to bleed every month so I know I'm not pregnant. I know I have this in here and I know it's effective, but I just want to know for myself and feel for myself. Also, other people explain that, it just helps with their natural cycle. They like to feel like this is going to happen every month, just like the sun rises every day and sets every day. The other things about IUDs, there are slight risks of placing them, what's called a perforation or a hole in the uterus. Extremely rare, but can happen. You can get an infection, but we do this under clean technique. So that's very, very rare. I will say that I do get a lot of people saying that they can feel their IUD afterwards. If an IUD specifically is misplaced, there could be sort of a sharp pain every once in a while when they make certain movements. And then the strings, of course. I always talk about the strings. The interesting thing is if you leave the strings really long, they can wrap around and actually be more comfortable for a partner who has a penis and is placing the penis inside the vagina so that they're not actually feeling like the end of the string. But we always offer to trim the strings as much as people want and talk about that.
Thank you. And you mentioned injectables, and I know that you did a lot of work around creating more access to self-injection. So can you speak a little bit about Depo Provera, what it is, and a bit about the work that you did advocating for people to have the option to self-administer?
Oh, sure. Yeah, thanks for asking about that. So Depo Provera, that's its trade name. Its generic name is depo-medroxyprogesterone acetate. The injection lasts for 12 weeks, but if you miss it at 12 weeks, up to 15 weeks is effective to do a re-injection. There are two options. There's an intramuscular injection and a subcutaneous injection. So what that means is that an intramuscular injection goes into your muscles. So it's a bigger needle, a longer needle. It is often injected into the upper arm where your biceps are. And then it also can be injected into your gluteus or your buttock. And then the subcutaneous injection is a smaller needle. And what subcutaneous means is underneath the fat. Their lower stomach is usually the most common place, but you can also do the anterior thigh. And generally, all over the world, people have been using subcutaneous Depo, I'm going to just say that for short, for self-injection. And it's been particularly popular in sub-Saharan Africa. But in the United States, we have mainly used the formulation of the intramuscular version and mainly given in clinic. And the reason for that is cost. The intramuscular formulation is a lot cheaper than the subcutaneous formulation at this time. And there just hasn't been a lot of information about the subcutaneous version, which is perfect for self-injection. So during the beginning of COVID, I realized that there was this contraceptive option that we could keep people on that they might not have to come to clinic for if they didn't want to come to clinic during a time when they were scared of contracting a virus. So in California, I finally got in touch with the chief of the pharmacy policy division, and he was able to get it in front of the right people in the Department of Public Health, and he got it approved for the time during COVID. So our clinic had a project with a bunch of medical students and pharmacy students who actually had been pulled from their classes. So it was perfect because they wanted something to do. So I had them call our patients and offer this. About 35% of our patients who were on the IM version were interested, but only 24% actually effectively injected. And a lot of the reasons why they weren't able to inject were entirely administrative, because the actual labeling that the FDA does still says that it's not for self-injection, even though we have a ton of evidence that from around the world and now in the United States also, that people are able to self-inject. And in fact, we have better continuation rates among people who self-inject, particularly younger people. So pharmacists would say that, or there would be a prior approval that was needed, or the insurance just wouldn't cover it. And then we've been talking to people about what their experiences were actually switching and how they would like providers to offer it. And this has become more popular now in many states. What I would say that drives me about it, I often wonder, just having a provider say, you know what, you could do this yourself if you wanted to. What kind of change does that allow for in someone's mind about what they can and can't do? But I will say again that it is really hard to make change. I just did a large national survey of providers who are experts in family planning across the country. And while 80% of them knew about the option for self-injection, only 40% were offering it. And so we still have a large amount of providers who don't even tell people that it's an option. And there's lots of reasons for that. When we ask people about that, they say it's because they think that people won't be interested. They think that maybe it won't be covered. These stereotypes and misconceptions, again, are just so pervasive and keep us from just offering things that are available.
I love the way that that work kind of subverts these power expectations and hierarchy and sense of like who can administer. And I want to talk about barriers, internal condoms, external condoms, and dental dams. In particular, I personally got really interested in understanding the history of internal condoms. I got really curious about how internal condoms might provide an option for people to take control of their own bodies. An internal condom is essentially the inverse of the condom that most people think about, which is designed to go around a penis. An internal condom is designed to go inside someone's body, so the vagina or front hole, depending on what language a person wants to use. And in particular, thinking about how that could afford a gender affirming form of barrier for folks who might not relate to their bodies in a way where it would feel good for a partner to wear a condom and for whom it might be empowering to wear one. And also thinking about folks who may not have full control over a situation. There could be many reasons for that, but thinking about like sex workers in particular who might just prefer to have control over what condom is used. And I'd love to hear from you, maybe Mariana, if you want to start about conversations you've had about barriers, both those ones that are more and less known.
Yeah. We have internal condoms at the clinic and also less known barriers such as spermicides or actually dental dams are becoming more popular these days. We've been talking a lot about to prevent pregnancy, but what we've found is internal condoms are also used for people, if they want to be more safe with the tools that they use for sexual intercourse, such as toys, to prevent sexually transmitted infections. So an internal condom can be a good option for people that are sharing toys, also for people, that are having penis vagina sex. They're very popular and I'm very happy about that. The dental dams at the clinic, they're flavored and they're often used for oral and anal sex. They're actually like a satin latex and it's only for one time use only. I've been giving people more than 5 and I'm like, use them and let me know if you need more. And a lot of people have tried them and they come back to the clinic. They're like, actually, they're really good. They prevent an STI and they were flavored. And I'm like, wonderful. And I feel like this is important to share, there are some methods that can prevent an STI. It's not only the external condom, it's internal condom, dental dams, and external condoms.
I appreciate that we're talking about these different kinds of barriers that folks might be less familiar with. And I recognize that we haven't talked about one of the first methods of contraception that people think about, which is the pill, which of course is a category of options, but people kind of might relate to it as a monolith. And I know that there have been a lot of different kinds of experiences people have about that form of contraception and the side effects. I want to share personally that something that has impacted me is learning from people I'm close to about, I think, fairly rare side effects, things that relate to changes in like vaginal tissue and pain. But I'm curious to hear from both of you in this broad category of, quote, the pill. What are some side effects that you are aware of that people might not know about or that might be maybe controversial even?
People definitely have mood changes with the pill and describe that a lot. Mood changes, weight changes. I guess this is slightly controversial, but changes in blood pressure. I do notice a lot of times that people, their blood pressure will increase once they've been on the birth control pill, and the evidence doesn't necessarily bear that out, but I have experienced that for sure. And if people are concerned about that, I think that's totally reasonable.
Yeah, just mentioning that estrogen containing birth control pills can potentially increase the risk of a stroke in individuals with migraines with aura. I think migraines with aura itself, it's already considered a risk factor for a stroke, and adding estrogen to the whole mix in your body can elevate the risk. If you have experienced migraines with aura, or if you see lights around you, or that the light bothers you when you have a migraine, and talk about the other options that are available for you.
I mean, in terms of side effects, not even just like talking about the pill, but any type of side effects, When someone comes to clinic and describes how they've experienced a contraceptive method, even if the evidence doesn't bear out on a population level that is statistically significant, I still normalize that for the patient because that was that patient's experience with the method. And so I just think it's important to say that data on a population level doesn't always bear out on the individual level. And we see individual differences that wouldn't be captured in studies. One other thing is that lately, from the international community specifically, I've heard people say, oh, in the United States, everybody's on the pill. And I just think that's a really curious narrative. When we talk to people about their histories of contraceptive use, tons of people tell a story of when I was 15 years old, my mom took me to the doctor and put me on the pill, and that was all they were told about. And so it's sort of like this self-fulfilling prophecy that we say that everybody is on the pill in the United States, and then people go to the doctor and then ask for the one thing that they know. But a lot of people that we talked to then narrated stories about how they didn't have a great experience on the pill. And that is how they then got to other contraceptive options as time went on and as they were in different relationships and in different situations. So that is something else that I think is really important to remember, is that we are all different people at different times, right? And so one thing that works for any of us in one particular time and place isn't necessarily going to work for us the next day or the next week or in 10 years, depending on what our gender and sexuality and experiences look like at that time.
Thank you for naming that. I'm a queer woman, and so that was one of the elements for me in making birth control choices where I felt like, why would I want to get on a birth control option that is always there when I don't always need it? And being able to talk openly about how identity connects with birth control, I think is really important. And we're going to be doing another episode in this series where we're really going to focus on family planning and reproductive care for folks who are trans and gender nonconforming. I know we want to talk about fertility awareness. Jen, do you want to take that one?
Sure. One of the reasons why I think it's important to bring up fertility awareness is because it's really one of the least talked about options. And one of the reasons for that is because there's not much money that can be made off of it. There have been apps that have been developed, but it's not a device, it's not a pharmaceutical. There's no way of making millions or billions of dollars off of it. And it is actually surprisingly more effective than we give it credit for. I actually think it's really important to talk to people about fertility awareness, both when they're choosing a contraceptive device or a pharmaceutical and when they're choosing to solely use fertility awareness methods. And there are various names for it. There's a 2-day method where you think about the type of cervical mucus that you have on that day or the day before, and you ask yourself, has it changed to be like an egg white? And if it has, then you don't have sex that day because that means that you are more fertile that day. So there's that method. There's calendar methods where you learn about the regularity of your ovulation, which is when an egg is released from your ovaries and you are the most fertile. So I always pull up a image to show people what is happening at different times with the uterine lining and with the hormones and with cervical mucus and then with an egg moving through the tubes into the uterus. I just think it's always important to remind people that it is very effective. And if people choose fertility awareness and condoms, that is choosing a method. I think just correcting kind of, again, that misconception that it has to be a device or a pharmaceutical for you to actively be doing something to be both preventing STIs and pregnancy. There's lots of things that we can do to prevent infections that aren't condoms. Paying attention to symptoms, talking to your partners about their symptoms, getting tested beforehand. It has to do with, relationships, communication, and knowing our own bodies and being in our own bodies.
I think there's a profound way that things like the fertility awareness method really have to do with trusting people to care for their own bodies and make choices for themselves, which is something that, as we know, traditionally medicine has not always done. So if we had more time, we would also go into the sponge, the diaphragm, perhaps spermicide, which came up briefly. We haven't talked about the Nuva ring, which is a silicone ring that contains hormones that can be inserted into the vagina or front hole and removed monthly. We've talked mostly about supporting folks who have a uterus, have a vagina, in choosing a form of contraception. And I wonder if in those conversations, questions come up about contraceptive options for partners who produce sperm.
Yeah, those questions come up often. People will say, listen, I really don't want to use hormones and I don't want to get tubal. Is there anything my partner can do? There are options for people who produce sperm, which include a vasectomy, which is where you cut the vas deferens. And it's actually a same day procedure. It's external to the body as opposed to people with ovaries where you cut the tubes, which is a tubal ligation. It is something we didn't talk about yet today, but that is an option for people who want permanent sterilization. And it also actually has benefits for decreasing the risk of ovarian cancer in the tubes. So oftentimes we will take larger portion of the tubes to decrease that risk. But those both are permanent sterilization for people who produce sperm and people who produce eggs.
Vasectomies are also reversible, though, I think, right? Within a certain amount of time, there's a fairly high chance in case they do make a different decision within a number of years. I don't know the stats on that, but just wanted to share that too.
Yeah. In addition to cutting of the vas deferens, there is an option for injecting a gel that is more temporary for blocking sperm to getting outside of the penis. Those are other options that can be used.
I would say like some people do come to the clinic asking, we don't do vasectomies. We don't talk that much about the vasectomy gel. Although we don't do tubal ligation at the clinic, there's one patient that came and she was under 30 and she was like, I know that I don't want to have kids. I don't want to be pregnant. I don't want to put my body through it. But everywhere I go, they tell me that I'm very young and that I should wait just in case I want to change my mind. I know that if I end up wanting a kid or a baby, I go to the route of adopting somebody. So if you're going to talk to me about all the birth control methods that are long lasting, I'm just going to cut to the chase. I'm not interested in any of those. What else do you have available? So I told her, I hear you. How can I help you? And she was like, if you can make a referral or the provider can give me the phone number of somebody, that will be very helpful. So I told her, you know what? Let me go and talk to the provider. The provider made a referral, made the appointment right there for her, and she cried at the appointment with us. And she was like, for the past 3 years, I've been hearing provider after provider just telling me that I need to wait. And she was like, that's not bodily autonomy. And after that, she made another appointment and she was like, thank you. Finally, it happened because you heard what I had to say and I got what I needed.
I love that story. Thank you so much for doing that work and listening to her. I agree that there are so many people who are turned away because of their age from getting sterilization. It's surprising to me because it's not the provider's life. And it's so important for gender affirming care. I think part of that story that I just want to lift up is the importance also of providers directly reaching out to the people who can do the surgery and actually explaining to them, like, I sat down with this person and it is my recommendation that they get this. My worry is always that then the patient is referred and then turned away again. And you just don't want that situation to happen to your patients. So what's so beautiful is also the effective handoffs. So thank you so much for making that happen. One other conceptual framework about talking about contraceptives, there are people who talk about menstrual regulation, which is where people use misoprostol, which causes cramping and contractions of the uterus, and they use that monthly as a way to bring on a period. And that is also an effective way of making sure that you do not become pregnant. It is not something that is named as a contraceptive method, and it is also not something that is named as a method of abortion because it is done before a pregnancy test or before somebody knows that if they're pregnant or not. But there are many cultures and many people who do that, and that is an effective way of preventing a pregnancy growing and continuing. And I think highlights the issue about where we draw the line between where we're naming things as emergency contraceptive, as abortion. And there's been lots of confusion lately about emergency contraception and whether or not that is terminating a pregnancy. And emergency contraception is certainly not terminating a pregnancy. And I would also argue that menstrual regulation is also not terminating a pregnancy.
Thank you so much for sharing that. I have never heard of that before, and I've got some learning to do. I love that there are so many different creative ways that people can find that work for them. And on the line of this differentiation between abortion, contraception, emergency contraception, and I wanted to take some time just to talk about what it's like to support patients in finding abortion care now.
Yeah, I think of reproductive autonomy as more of a spectrum. And so even when people choose a contraceptive option, I say, contraception isn't always totally effective. And if there is a time when you become pregnant and you do or do not want to be pregnant, I am here to talk to you about your options. In terms of abortion, we are very lucky right now to be living in the state of California that is both protective of patients who are seeking abortion care and also of the providers who are providing abortion care. There are pills that you can take. One of them is a combination of mifepristone and misoprostol, although you can also do a misoprostol only medication abortion. And then the other option is a procedure and is a small tube that's a vacuum that helps remove the contents of the uterus. When the gestational age gets a little bit higher, there are other instruments that sometimes need to be used. In terms of medication abortion, there are various options for receiving pills. And those options include going to a clinic and then picking up the pills at a pharmacy now, because it is now available to receive the medications from a pharmacy and doesn't have to be provided directly from a clinic. And then there are telemedicine options where you can talk to a provider and then get the medications mailed to you or to pick them up at a pharmacy. And then there are options for receiving the medications online yourself from an online pharmacy or from different online sources like Aid Access. And plancpills.org actually is a great resource of a website that both tells people about their options locally at brick and mortar clinics, telemedicine options, and then has vetted online sources for pills that are both effective and reliable. There is also a hotline of clinicians, all options, of people who are trained to talk people through all the options, which also includes adoption and termination. There is also a hotline called the M&A hotline, which is the miscarriage and abortion hotline. And that is clinicians who support people who are having a miscarriage or who have already received the pills from an online source and who are managing a miscarriage or an abortion at their home without seeking care from a brick and mortar physician or advanced care provider. So that hotline is very helpful and has been able to support thousands of people over the last 3 years across the country.
Incredible. The resourcefulness and tenacity of our community and making sure that people continue to get abortion care. And of course, naming that not everyone will be able to access the care that they need. Thank you both so much for contributing to making sure these options all remain available. And I want to transition to the last question I like to ask our guests, which is bringing in the imagination from a perspective of movement building, thinking creatively and investing in new possible futures is so important. And so I like to ask, what's something you hope we can create by coming together for sexual health?
My hope is to create more equity and education surrounding reproductive rights, ensuring that individuals receive the care that they need and they deserve, and keeping in mind bodily autonomy. My hope is also that the information that is given to people in the United States, it's available not only in English, but in other languages.
My hope would be that by coming together, individuals can be in their bodies without feeling any shame or judgment and really exploring their bodies and feeling that they have the choice in this lifetime while we're here together to choose the things that make them feel good and make them feel like they're living the kind of lives that they want to live, and that other people can't tell them whether or not that's a good choice or a bad choice. It is their choice, and that is the most important thing.
Thank you both so much for sharing those visions and the work you do every day to move us collectively towards those visions. It's been really a pleasure to get to talk to you both and learn from you.
Thank you so much.
Thank you, Tammy.
Thanks for listening, and please follow and rate us wherever you get your podcasts. This will help more people find us. Check out the show notes for the resources mentioned in this episode. You'll also find a link to the transcript of the show. Connect with us on Instagram at ComingTogetherPod, on Twitter at CaliforniaPTC, and at ComingTogetherPod.com. This podcast is produced by me, Tammy Kremer, and is edited by Isaiah Ashburn. Thank you for coming together for sexual health.